Sabrina, I don't know about you, but I, in practice, am seeing more and more people, and actually worryingly more and more young people, with real concerns about the way they look. Their body doesn't look right, that I think isn't proportionate to the level of concern that they have. Have you found that?
I completely agree with you, Christian. I mean, my practice, I see almost 2 patients on a daily basis that I suspect have body dysmorphism. You see this more and more in young people. They're looking at social media, they're looking at celebrity, looking at photoshopped images, and are so unhappy with how they look, and actually believe that photoshopped look is real.
It's a real thing. And body dysmorphism, I should say, it's kind of hard to describe. I often, simplify it to what you see in the mirror isn't really what other people see of you, in a nutshell.
Exactly.
Isn't it?
Exactly. But often they're in denial of it because they're actually looking for it. So it's not surprising when I have patients who come in with a phone and they tell me that in this light, when I look down like this, I don't like how my skin falls. And it's like, why would you be looking at yourself in that particular way?
Yes.
Some of them notice it, they're in different lights. It's fine if you're sitting in a train, you know how the fluorescent lighting from the top makes your under eyes look really horrid in a train. And if you notice it that way, it's fairly reasonable. But these are young people who are looking at social media, looking at their phones, and they're looking at their faces from all sorts of different angles, different lighting, and they want to look perfect in every angle, in every lighting, and they don't understand that this is
and there's
obsessive.
This strange phenomenon that even though we all kind of know that these pictures are heavily doctored, and pretty much any photo of me that's ever put out there is, I make sure, heavily doctored. Even though we know that, we still sort of believe the picture, to a degree. It's weird, isn't it? And it's a powerful force, but it's quite a pernicious force in the effect that it's having on people.
It is, because, we know the evidence, you have at least 20 pictures taken on your phone, and you will only post one. And you post the one...
Speak for yourself.
No. You only post that one where you think that's a fair representation of how you would like to look and present yourself to the world. And so this happens to people who don't even suffer with body dysmorphism. So, but with the body dysmorphics, it's an unreal level. It's very doctored. Some of them don't want, actually, interestingly, any photographs taken of them. So it's very telling when they come in to the clinic and they're having a consult with me, they'll say, sometimes they don't want to remove their makeup, and they're having a consultation for me to actually assess their skin, their under eyes, and they don't want to take their makeup off. They're very tearful. Some of them come in with glasses, they don't want to take their glasses off, and some of them tell me, I won't get photographed. I cannot bear to see a photograph of myself. And these are all telltale signs of a patient with body dysmorphism who hasn't actually realized that they have body dysmorphism.
And they're looking, and this is for me the really important part, they're looking for treatments that pretty much most of the time are entirely inappropriate usually.
Completely, yes.
Or excessive or extreme, aren't they?
And they see themselves, it's magnified. For them, the smallest little defect, if you call it that, is so magnified. And they will use words like, I hate how I look. I can't bear how I look. Often they will suffer with anxiety or depression, particularly the older patients, or even the younger ones. They have a generalized anxiety, and they are obsessing about their appearance, which is really disproportionate completely to how they look in clinic, when they present to you. And that's the worry. The worry is that they see something different in the mirror than what you and I would see, and we would accept as normal. And
I'm very conscious we're saying they a lot, but actually I want to bring it back to us, the doctors, because nothing makes me more angry these days than the photo in the paper of what I think is an abused patient. I think is a vulnerable but abused patient with the ridiculous, excessive lips, the surgery that should never have been performed. And every day there's a new story, a new photo, of someone who's clearly vulnerable, clearly needs help, and I think has clearly been taken advantage of. So we doctors need to be very, very careful about identifying those patients and making sure that we don't become part of that cycle of just treating them because maybe it's just easier.
Yes.
Because they can be very tricky patients to handle, can't they?
They are tricky patients to handle, and sometimes they're tricky even at the consultation stage where you've identified there's a problem here. There's potential body dysmorphism. I've had that happen often enough to me, and I know we've discussed this before, where, you know, I've broached the topic with them and said, look, I think you have or may have body dysmorphism, and or that your expectations are unreal, and you do need not only to see a, you know, have a COP score.
So what is the score? Talk me through it.
So essentially it's a self-assessment questionnaire that's available online, and it goes through a couple of questions, and essentially it's asking you, you know, how much does your appearance bother you? How many hours a day are you spending worried about your appearance? How often are you looking at yourself or avoiding looking at yourself? Does this affect your social life? Does it affect your interactions with your friends, with your family, your sexual life? And you know, it's scored, and obviously if you score high, then you have body dysmorphism. And the best thing at that point, if you do this online self-assessment, is to then seek care with your GP and get referred for cognitive behavioral therapy.
See, I'm skeptical because I think the truly body dysmorphic is either not going to do that questionnaire at all, or will not answer the questions truthfully. And I say truthfully, they may lack insight, because I think so often there's a huge degree of lacking insight into the extent of the problem, which is where I think that questionnaire falls down. But the important thing is actually, it's not the questionnaire that's the final stage, it's us.
I agree. But this is where it becomes important, because often I find patients telling me, well, why are you telling me you can't treat me? That practitioner is willing to treat me. This is where it comes down like a pack of cards, because here you have somebody saying you have body dysmorphism, but then you have a couple of other practitioners, because that's what a body dysmorphic patient will do if they're in denial or they don't accept that the condition they have is a mental health issue, and it can be fixed very easily with a bit of filler, a bit of toxin, and so they will go to another practitioner. And then when they go to the other practitioner, perhaps the other practitioner is not as au fait with diagnosing body dysmorphism.
Oh, it's ethical, let's just say it. You know.
Yes, may not be ethical enough, and they may feel, oh well, yeah, of course I'll inject. So it then starts this vicious cycle where they've got a treatment somewhere else, and invariably patients will not be happy because they have body dysmorphism and they're seeing something magnified that doesn't exist. And so then they start hopping from clinic to clinic, practitioner to practitioner, either having surgery or non-surgical treatments to satisfy some deep emotional desire, which is really a mental health issue. So very often when I have patients who come to the clinic who clearly look as if their face has morphed, I know they have body dysmorphism, because I know, okay, if you're walking around looking like that and you think that looks normal, then there is an issue here. And the history is telling. They'll have had rhinoplasty as a youngster, they'll have had a breast job as a youngster, they'll have had lips filled, and you know, it invariably starts with that. If you ask them about a history, they may have other mental health issues, you know, they may have childhood trauma, they may have anxiety, they may have obsessive compulsive disorder. So it goes hand in glove.
Absolutely.
And they've had lots of treatments. They've never been happy with their treatments.
Let's talk for practitioners watching. I think it's really important to be aware that actually going on treating and not identifying body dysmorphia, even if you feel you're not qualified to do it, can be seen as a case of negligence.
Definitely. Medico-legally, because consent is not valid. Because you need to have a proper mental health status for consent to be valid. And
that's a really serious point to make, that I don't think enough practitioners, well, it's very obvious from looking at photos in the press that not enough practitioners know this. And I wish more would, I think, take more responsibility. And I fully appreciate the patients themselves can be difficult, and we can talk about that in a bit. But the advice.
But may I bring in something here, Christian?
Yeah, no, please.
There are a lot of practitioners who are body dysmorphic. So
that's where we were going to go.
Yeah, and this again has it's very visible when we attend conferences and meetings. We have practitioners who, you know, I look at them and I think, okay, what happened there.
Yeah.
But also they perhaps think that they're celebrities or rock stars, or they're mimicking somebody that's, it's not a medical professional. And they've got big lips, big cheeks, they've got, in fact, complications on show under their eyes and on their face, and they're oblivious, and they're at a conference. And so here are practitioners, dysmorphic practitioners, who are treating
so
dysmorphic
I have a theory
patients.
on this. I have a theory that, the more patients, let's just say, who have had work done that you're seeing, the more out of touch with what normal is you are possibly likely to become. And that's only going to escalate and escalate and escalate. So how do we keep ourselves in check? How do we ground ourselves back down to earth? It's a tricky one, isn't it?
It's a tricky one because there's a financial incentive with treating, and it's always easier to treat rather than have that difficult conversation. And also, Christian, it comes with experience. So in the beginning, when I was, much younger, I ducked.
A few years ago.
No, not so. It was quite some time ago. I ducked, and I sort of didn't want to have that conversation with the patient because it was very uncomfortable. So sometimes, when you say, okay, you have a little skin cancer and you're going to treat it, it comes out quite normally. But to have a conversation with a patient that they may have a mental health issue and body dysmorphism, and then the patient starts by saying no, and they don't know what I'm talking about, and becomes a very aggressive consultation, becomes very embarrassing. They're upset, you feel upset, and you don't know how to handle the situation. Unfortunately, as I got better with handling the situation, and I came straight out and told the patient, look, I suspect you may have body dysmorphism. It doesn't mean you can't have treatment, but you'll perhaps be happier with the outcomes of your treatments if you did have psychotherapy and behavioral therapy. In fact, then you may not need to come and see me or another practitioner after the therapy, but if you did, you'd be happier with the outcome. So it's not like we're turning you away now, but we're doing what's in your best interest.
And I think a key thing for practitioners, again, is that taking on one of these patients and just being, oh, you know what, I don't want to have that conversation, we'll just do the treatment because, well, the bill needs paying, and quite frankly, it's easier than having a row. They're probably not going to be a very happy patient, whatever the treatment you do. They'll be back with, it's not right, it's not good enough, I want more.
Completely. And sometimes, they're not happy patients because you turn them away. And I've sort of been on the receiving end of this, where you get a bad social media review or an online review because they paid money for a consult, and I said, I'm not going to be able to treat you, and you do need to go away and, consider that you have body dysmorphism. But
you've done the right thing, and that's the ethical, responsible thing, and that's what this is all about.
Yes. And at the end of the day, when I see that review online, and although it pains me and I'm disappointed and hurt, I think, my God, thank God I didn't treat this patient, because if they could not even understand the consultation and the recommendations made in their best interest, then just imagine if I had treated them because I was choosing the easier route. That's a recipe for disaster, and this patient would be significantly unhappy, would have, had a alteration to their appearance that they would be unhappy with. It would have just worsened their body dysmorphism quite significantly, and that's not in their best interest. So at the end of the day, I still feel that's fine. I did the right thing by the patient, and I think that more and more practitioners have to identify that, get comfortable with that. Maybe they need to be trained.
I think my conclusions really for practitioners are, it is important that you are identifying patients with body dysmorphia. You have a clinical responsibility, an obligation to do so. And no, it's not necessarily easy to do. And yes, patients may get annoyed with you, and they may go off somewhere else and get the work done somewhere else, but you have done the right thing, both ethically and also medically. And I think, Safe Face can help with that. Should you get one of those complaints in, they can help guide you through that complaint and also improve your practice afterwards by learning, well, where actually did you perhaps not ask the right question, or how could you have done that interview with that patient a little bit better to get the information out? And that's a really important skill.
It's really important because Safe Face as a body is ethical, it's responsible, and it's actually looking at these difficult areas. That's why we're having this conversation on body dysmorphism. As an aesthetic industry, people don't really want to talk about body dysmorphism because it's not considered sexy, and we're actually saying, please don't inject. please don't operate, so we're financially not making it viable for practitioners, but in the long term, we're doing what's right for the patient. And that's what Safe Face is about. So that's why we're having this discussion. So I think it's important that we start the discussion, we carry on the discussion, and that Safe Face as a body is supporting practitioners in how to reflect on why they had a complaint, how they could have handle the complaint better, and what the learning points of the complaint were, so that it's not being repeated in their practice.
And the other point I want to conclude with really for practitioners is the thing you brought up, which is, are we losing touch with what normal is? Now I know normal is a terribly un-PC word to use, but nevertheless, I think it says it all. Are you seeing so many treated faces, or even is your face becoming so treated that you've now completely lost touch with?
Well, the normalization of
procedures,
and Korea as a country is a hallmark of this, where it's completely normal, and the teenager is given an Asian blepharoplasty and a nose job as their 16th or 18th birthday present. So as a country, for Korea, that's completely normal. It's a social status thing. They've had surgery. And that's a worry. That's a worry, because you're not empowering these teens or these young people to be comfortable in their own skin, and to recognize that we're all unique, we all look different, and we have to celebrate that, instead of creating these little clones of everybody looking the same, with the extremely done cheeks and the frozen forehead, and the huge lips.
Look at these eyebrows.
Yeah, look at mine.
There ain't no tops in there, right?
But you know what? And the big lips, the high cheekbones, and the completely frozen face, that's not normal. And
I think for patients as well, the key areas really are, choose your practitioner wisely, and Safe Face can help you with that. Be aware, either in your friends, your children, if they're teenagers and are coming into a world that is, where you're being bombarded with imagery, but it's heavily doctored imagery, that this is a very real thing. You may not be entirely aware of it yourself, but if a number of practitioners have started to hint at the possibility of, do listen, because it is important, and it may well get worse, and it can lead to really destructive and damaging, including self-harming behavior. So it's not that the doctor is not being helpful, it's not that they're being unkind or being mean or anything like that. In fact, I would say they're being more responsible possibly than any other doctor that has taken you on for treatment.
Yep, I agree.